Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, welcome, bitches. This is Kevin with the Transformation Nurse Academy podcast. I'm going to give you a little special episode today because we had a question from a listener. Her name is Debbie Hasty. Debbie and I have known each other for quite a while. We haven't worked together in a while, but we've known each other for more than 20 years. She's a PACU nurse and an ICU nurse. I don't know what the hell she does now, but she follows us on the Transformation Nurse Academy Facebook page, and she asked a question. And the question is, can you please discuss these with scenario? So recently I did a podcast on respiratory assessment and talked about different devices and stuff, the different oxygen devices. And so the question she said was, can you discuss these with scenarios? For example, a patient with COPD on home O2 sats, on home oxygen, should I say, with O2 sats 94% when they're on 3 liters. And so she's like, what should a nurse do to be prepared, in this case, for desaturation? First, let me start out by saying, again, my name's Kevin. I'm a certified emergency nurse. I'm also a certified sedation registered nurse through the American Association of Modern Sedation Nurses. So we're going to dive into this question because it's very important. First, let's understand this. Let's talk about the patient's condition, COPD. So there's a thing called a gold standard. So first, we need to assess the patient's COPD severity using the gold standard, which stands for Global Initiative for Chronic Obstructive Lung Disease Classification. And there's 4 categories of gold 1, 2, 3, and 4. So gold 1 is mild, gold 2 is moderate, gold 3 is severe, and gold 4 is very severe. It's called the forced exhale ventilation. So gold 1, a mild COPD patient has about 80% of their forced exhale volume. They're able to get out 80%, when they exhale. Gold 2, which is a moderate COPD, they can get about 50%. So then a patient with severe COPD, 30% is all they can get out when they exhale. And then when you have gold 4, very severe, you only have less than 30% of forced exhale ventilation, which means they're holding on to a lot of water because you breathe in oxygen, you breathe out CO2. And so, if you can't get out that CO2, you're going to wind up holding on to it. And if you hold on to CO2, blood vessels in your brain vasoconstrict. COPD patients are at risk for cardiac arrest, myocardial infarction, pneumonia. All right, so let's talk about gold 1. Gold 1 patients are typically managed with short-acting bronchodilators such as albuterol and ipratropium. Gold 3 and 4, likely long-acting bronchodilators, inhaled corticosteroids, and possibly phosphodiesterase. So I don't know if you know phosphodiesterase. I know I'm not saying it right, but that's Viagra. Viagra was originally meant for women for pulmonary hypertension and cardiogenic issues. It's just they let men into the fucking study, and our dicks got hard, and then that's $1 billion industry. So patients may be on phosphodiesterases, for COPD as well. So if you do have a patient that's going to be receiving conscious sedation, and it may not always be optimal. If you work in the emergency room, it may not always be possible to pre-plan, but you still should look into the patient's chart to see what they've been doing, because it may give you a better hint on how to prepare for this patient. If you work in surgery centers, or you work in the PACU, or you work in surgery period, and it is a planned surgery, then we should be looking at these things that I'm going to talk about. That way your patient has a better outcome. So for example, pre-procedure planning, medication optimization. Ensure that the patient has their COPD well controlled. I've been teaching a while, and I always tell people patients are fucking non-compliant. So you have to make sure they're compliant, and you have to be very forthright about what's going to happen if they aren't compliant. But if they are COPD patients, we want to make sure they're well controlled. If they are in category of gold 3 and 4, they should be on regular long-acting bronchodilators and possibly systematic steroids. So that way and they should be continuing this up to the time of the procedure. So that way it can kind of help mitigate any risk. Sedation considerations, you want to consider potential respiratory distress. Again, they already have problems, gold 2, 3, and 4, they kind of anywhere from moderate to severe. They have a hard time expelling their volume. And we know that benzos and opioids, they cause respiratory distress or respiratory depression, should I say, my bad. So given the potential for respiratory depression, you want to offer sedatives that have minimal respiratory impact. So like benzodiazepines, like midazolam, are common with the use of low effective doses. So start slow, go low, start slow. An alternative though is called dexmedetomidine. Can't even say it right. Dexmedetomidine. Dexmedetomidine. It can be used as an alternative with sedative, it has sedative properties with less respiratory depression. So the mechanism of action of this medication, it's a alpha 2 adrenergic antagonist. Primarily binds with the alpha 2 adrenergic receptors in the brain and spinal cord. These receptors are part of the sympathetic nervous system, which controls, mainly the body's fight or flight. The sedative effects, again, by activating these alpha 2 receptors, it reduces the release of norepinephrine, neurotransmitters, usually increase alertness and arousal. So this reduction leads to sedation and a calming effect without significantly affecting the respiratory function. It does have some type of analgesic effects as well. And then besides sedation and analgesia, it can reduce anxiety. So it's kind of like a beautiful drug, but can you use it in conscious sedation? A lot of nurses say that in California, you're not able to push conscious sedation medications and stuff. But there is a statement by the Board of Nursing, and they're very clear in their statements. But the problem is people won't read the damn statement. So can an RN, registered nurse, perform conscious sedation in the state of California? So this is what it says. It says, it is within the scope of practice of a registered nurse to administer medications for the purpose of induction of conscious sedation, short-term therapeutic and diagnostic procedures. So authority for the RNs to administer medication derives from Section 2725B of the Nursing Practice Act. This section places no limits on the type of medications or the route of medication. There's only requirement is that the drug be ordered by one lawfully authorized to prescribe it. In administering medications to induce conscious sedation, the RN is required to have the same knowledge and skills as any other medication for nurse administers, if the nurse administers. This knowledge base includes, but is not limited to, effects of medication, potential side effects, contraindications of the medication, the amount of medication to be administered. The requirement skills include be competent to safely administer the medication given the route, know the potential complications, recognize emergency situations. The RN would be held accountable for knowledge of this medication and for assuring the proper safety measures. So like blood pressure, respiratory rate, level of consciousness, oxygen saturation, EKG. And then you have to be able to be trained, says immediate availability of an emergency cart, which contains resuscitative antagonist medications, meaning antidotes, airway and ventilation adjuncts, defibrillator suction, sorts of administration of oxygen to up to 100%, and the national standards inducing conscious sedation. National guidelines for administering conscious sedation should be consulted in establishing agency policies and procedures. So if your fucking hospital or organization doesn't have one, then you should get one, because ultimately then you would be totally responsible. The registered nurse administering agents to render conscious sedation will conduct a nursing assessment to determine that the administration of the drug is in the patient's best interest. So even if a doctor orders it, you're still responsible for knowing, is this medication in the best interest of the patient? So you got to know the right medication for the right procedure. The RN has the right and obligation to act as the client's advocate by refusing to administer medication or continue to administer any medication not in the client's best interest. And that just doesn't apply to conscious sedation. It applies to everything. The institution should have in place a process for evaluating and documenting the RN's demonstration of knowledge, skills, and abilities for the management of clients receiving agents to render conscious sedation. Evaluation and documentation of competency should occur on a periodic basis. Certified registered nurse anesthetists, by virtue of advanced education and practice in their areas of specialty, have met the requirements to safely administer the class of drugs in question. So in other words, if you are not a CRNA, then you need to make sure that you are trained, you're competent, and you can do that by taking one of the courses from the American Association of Modern Sedation Nurses and get certified. All right, so again, let's confirm the patient's baseline respiratory. So before we deal with a COPD patient, let's do a pre-procedure assessment. What is their respiratory status? What is their O2 status? What is their carbon dioxide levels if it's available? Ensure that the COPD patient is well managed with current medication. And then look at the sedation preparation. Since the patient is at risk for respiratory depression, it's important to use the lowest effective doses of sedatives, preferably short-term acting like midazolam, to minimize the impact of their breathing. In other words, slow on, quick off. During the procedure, oxygen administration, continue the patient on their current oxygen therapy, but avoid increasing the flow rate unless absolutely necessary. Excessive oxygen can, it's not saying it will, say can suppress the respiratory drive, especially in those that have chronic CO2 retention. That makes sense? But you got to use it, you got to use it. But there's a difference between ventilation and oxygenation. So you got to know the difference between those two. You don't always have to intubate people. Head to chin lift works. O2 oropharyngeal airway works. A nasal pharyngeal airway works. And an ambu bag works if it's used correctly. So during the procedure, oxygen administration, continue the patient on their current oxygen therapy, but avoid increasing the flow rate unless absolutely necessary. All right, so monitor them closely, monitor their oxygenation saturation, monitor their respiratory rate. If the respiratory rate is low, they're going to hold on to CO2 even more so. So you may have to help bag them. You may have to help, you may have to stimulate them to get them to breathe. If available, the capnography to monitor CO2 levels is the best. That's the gold standard. So if you guys are not using CO2 as the gold standard, then you're not meeting the national gold standard. They're not saying that it's required. They say it's recommended because, they don't want to spend the money. The hospitals don't like to spend the money if they don't have to. In the event of desaturation, immediate response, if the patient's O2 sat drops significantly, so let's say their sats are 94% on 3 liters. So how low is it appropriate? Well, one, as a nurse, you have to ask the physicians to provide you parameters. So if you have anesthesia there, ask them. If you have your ER doctor, your PACU doctor, your surgeon, ask them to give you a parameter of how low we can go before they want to intervene. Now, from an experienced nurse, if you have somebody that's a COPD patient that's 94% on 3 liters, I would take them off to see what he sats on room air. So you'll know how you're going to get a baseline if you don't perform this test. But you want to get a baseline. I don't really panic if somebody's sats are in the 80s. I look at the numbers, but I also look at the patient. Is the patient talking to me? I know they're over here fucking talking. I can't even hear myself talking so damn loud and shit. Fucking Daniel. So when their O2 sats are low, where are they on room air? So you'll know how to better assess them. But when you have somebody with sats 60, 70, 80%, are they still talking to you? Are they coherent? Are they alert and oriented? Are they confused though? So these things that you have to look at, you can't just look at numbers and treat the numbers. You got to treat the patient. So you may have to increase oxygen saturation. You may have to increase your ventilation rate. But remember, over-oxygenation can be harmful as well. So you want to titrate it slowly. Give it a chance to work. And then also help with their ventilation. Maybe they need PEEP, positive expiratory pressure. In the event of a desaturation, though, a patient's O2 sats drop significantly, look at the patient first and then start looking at the numbers. So increase the oxygen. If it doesn't improve their saturation, like I said, you can try the respiratory rate. You can try CPAP. You can see if we need to put them on BiPAP. But you want to have a bag mask device ready, preferably with a PEEP valve on it and a manometer so you can see how much peak inspiratory pressure you're actually ventilating them. So again, you want to monitor them closely until they're fully awake and the respiratory rate and the respiratory function are stabilized. You want to ensure that they return to the baseline and reassess the respiratory status before they discharge. All right, so I hope I answered some questions for you. If you have more questions on conscious sedation and sedation of COPD patients, don't be afraid to ask us. All right, you guys, I appreciate you. I hope that you have enjoyed this little tidbit. You guys have a great day. Peace, bitches. Thank you, Debbie, for a great question. Keep them coming. Woo! And Daniel, shut the hell up.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.